This is an overview of the Fugl-Meyer assessment. What I will cover in this overview is the purpose, clinical utility, and scale construction. I will also cover the standardization of the assessment and its reliability and validity, as well as details on the multiple attributes being assessed, then to conclude with the overall utility of the assessment. The Fugl-Meyer is used to evaluate and measure recovery in post-stroke hemiplegic patients, specifically on motor functioning, sensation, balance, joint range of motion, and joint pain of the affected side. There is no formal training of this tool, but just a review of the manual and standard protocol procedures. I have use of this tool to be clear and concise with step-by-step instructions. The Fugl-Meyer is free and readily available online to download. Parts of the tool require certain equipment at minimal cost and can usually be found anywhere. It takes about 45 minutes to complete the full assessment and shorter if you're doing just a specific subscale. It is best administered on a one-to-one basis with the patient in a quiet area when they are maximally alert. The Fugl-Meyer is an excellent tool to have on hand if you are working with stroke hemiplegic patients. Equipment to have readily available include a chair or mat, a bedside table, reflex hammer, cotton ball, pencil, a small piece of cardboard or paper, small cylinder container, tennis ball, blindfold, and a stopwatch. In regards to the scale construction, the assessment can be administered in full or by subscale. There are 5 subscales and each domain contains multiple items, each scored on a 3-point ordinal scale. The maximum score a patient can receive is 226 points. The 5 subscales of the Fugl-Meyer include measurement of motor function of the upper extremity and lower extremity, sensation of the affected side, balance, passive joint motion, and joint pain. Each item is scored on a 3-point ordinal scale. A score of 0 is obtained if the patient cannot perform the task. A score of 1 is obtained if the patient performs partially, and a score of 2 is obtained if the patient performs the task fully. For the first subscale of motor function, we measure movement, coordination, and reflex action of the shoulder, elbow, forearm, wrist, hand, hip, knee, and the sole of the foot. The upper extremity has a max score of 66 points, and the lower extremity has a max score of 34 points. Here are some images of some items of the upper limb section, which include wrist control and 5 different grasps. The second subscale is sensory function, measuring light touch and proprioception, receiving a max score of 24 points. With light touch, you measure the belly of the bicep muscle, palmar surface of the hand, thigh, and sole of foot. With proprioception, patient is supine or sitting for upper extremity, measuring the shoulder, elbow, wrist, and thumb. Supine for lower extremity, measuring hip, knee, ankle, and toe. Here are some images of some items of the sensory section. The use of a cotton ball for light touch, and using specific hand placements for measuring proprioception. The third subscale, balance, measures sitting and standing to receive a maximum 14 points. 3 details are evaluated in sitting, which include sit without support and maintain position, a parachute reaction of non-affected and affected sides separately while the patient is blindfolded and pushed. And then 4 details in standing, which include supported standing, standing without support, and standing on non-affected side and affected side. The 4th and 5th subscale includes joint range of motion and joint pain. Each can have a maximum score of 44 points. Evaluation of passive joint motion for most joints of the affected limbs include the shoulder, elbow, forearm, wrist, finger, hip, knee, ankle, and foot. For joint pain, evaluation of occurrence of joint pain during and at the end of passive range of motion. The standardization of the tool is excellent. A published manual can be found online for free, which outlines specific procedures for administration, scoring and interpretation, and provides evidence of reliability and validity. This tool is used to measure and evaluate, so there are no norms available. The reliability of the tool is excellent. There are more than 2 well-designed reliability studies completed with adequate to excellent reliability values. Values include inter-rater reliability, test-retest reliability, intra-rater reliability, and internal consistency. The Fugl-Meyer has excellent validity. There are more than 2 well-designed validity studies supporting the measure's validity. I was able to find at least 11 different studies. Content validity was excellent, statistical methods were used, and the measure is comprehensive and includes items suited to the measurement purpose. Construct validity was excellent, with more than 2 well-designed studies that have shown the instrument conforms to prior theoretical relationships among characteristics or individuals. To name a few, the strength of the association shows excellent correlation of the Fugl-Meyer with the Barthel Index, FIM, Action Research Arm Test, Jebsen-Taylor Hand Function, Berg Balance, and Grip Power Test. Excellent concurrent criterion and responsiveness shows. The Fugl-Meyer assessment is an excellent clinical utility, especially for its ability to evaluate on subscales alone. It is easily and readily available online with step-by-step instructions. Several studies have shown and support the reliability and validity of this tool. It is considered by many in the field of stroke rehabilitation to be one of the most comprehensive quantitative measures of motor impairment following stroke, and its use has been recommended for clinical trials and stroke rehabilitation.